All right, going to give everyone just a minute or so, or 30 seconds to come on in. This is Brandon Gare with the National Minority Quality Forum. Thanks for joining us again on our Friday webinars. We try to educate and folks in various areas of healthcare and health equity. We're going to be talking about kidney care. Kelelaye, go ahead and lead this panel. You have a ton of panelists and a lot of information to disseminate. So I get to him, but I just want to make two quick announcements about next week is Congressional Black Caucus and Congressional Hispanic Caucus Week. And we're going to have a couple of events that NMQF will participate in. One will be on Wednesday morning with the National Medical Association, their PDS program. Two, on that same day in the afternoon, we'll be doing a panel with AAMC and NHMA at their AAMC headquarters. And then we'll have a reception following it. And then finally, Dr. Puckman will be speaking on a panel this Friday with Merck. So we'll have a busy week, but good way to kick it off is starting a little early on Friday. And I'm going to turn it over to Kelelaye and get us started.
Thank you, Brandon. Happy Friday and welcome everyone. We have great webinars every Friday and amazing speakers, as Brandon said, but do we have quite the lineup for you all today? So we honestly have a powerhouse and I'll introduce them to you in a moment. But I am Kelelaye Emiru. I'll be your moderator for this important conversation. My role with NMQF is Vice President for the Center for Professional Strategic Alliances at National Minority Quality Forum. So my team serves as the hub for professional groups and strategic alliances. So we're all about fostering collaboration with other organizations. We create working groups and knowledge sharing. So creating platforms to really work on joint initiatives and tackling health disparities across disease states. So without further ado, let's talk about the purpose of today's webinar. I know we'll be discussing a number of topics, including the potential impact of CMS's plan to add phosphate lowering therapies to End Stage Renal Disease payment bundle and the implications of that on patients as well as kidney care. We'll also introduce Nephrologists for Equitable Kidney Care, which is an alliance that NMQF is standing up, and explore advocacy strategies for improving access to improve overall care. Let me get started with introducing our panelists. And before I do that, let me quickly remind the audience, if you have any questions throughout the program, where we'll ask you all to put it in that Q&A function, chat function, and then we'll get to them towards the end of the program. So for the sake of time, I'm going to introduce the speakers today, and I'm pleased to have every one of the panelists and speakers. Let's start with Dr. Cameron Blackmore. She's a health policy advisor for Office of Congresswoman Terry Sewell in Alabama's 7th District. She's also an expert in public policy with a focus on health equity. We also have with us Dr. Randall Maxey. He's the past president at National Medical Association. He's the chairman at American Alliance Dialysis, and he's a practicing nephrologist with extensive leadership in addressing health disparities and nephrology care. We have Dr. Williams as well, Dr. Laura Williams. She's the Chief Medical Officer at Ardelyx. She's a physician scientist with over 25 years in pharmaceutical drug development, who's led multiple drug approvals. And we have Dr. Frida Fisher as well. She is the founder of Midtown Atlanta Nephrology, medical director of a nonprofit dialysis unit as well. And she's got a social media influencer. She's a social media influencer as well, and a medical expert with a following of over 500,000 YouTube subscribers. So let's make sure she gets to 501,000 before the end of the day. We're also joined by Crystal King. Crystal is a founder of executive director at Kidney Champion Foundation. Crystal shares an incredible personal journey. She uses her voice as kidney transplant survivor, and she advocates. Her work is recognized nationally in terms of kidney care and kidney health equity. We have Dr. Sandra Gatson as well, who's also a past president at National Medical Association. She's also a practicing nephrologist and really a pioneer when it comes to establishing freestanding dialysis centers, as she has in Northwest Indiana. We have one more speaker, Dr. Ruby Hartford. She is the CEO and president at Atlantis Health Group in Puerto Rico. So she's an advocate for kidney disease patients. She's championed inclusion in Puerto Rico's COVID-19 emergency management plan as well, and brings the wealth of experience in terms of how to reach out to this rural communities. So let's get started now. I want to thank all my speakers for joining us, and we'll just jump right into the program. Let me briefly start by introducing the Nephrologists for Equitable Kidney Care. We've recently launched this alliance, and it's really an alliance for collaborative and a collaborative network focused on reducing disparities in kidney care, so particularly in underserved communities. It's an alliance under our larger organization, NMQF, and we hope to provide that platform for nephrologists and other healthcare professionals and even advocates to share their insights, best practices, and innovative solutions, just thinking about how we can better kidney health and outcomes for marginalized communities. And I'll say our vision and mission aligns with that of the larger organization. The vision for this alliance is to ensure equitable access to optimal kidney care, because we understand that not even the general public isn't receiving optimal kidney care. So ensure equitable access and then optimal kidney care, and promote professional excellence for nephrologists who champion health equity. So that is our mission, is to advocate for optimal kidney care and focus on these groups and marginalized and underserved communities that we have that we've worked with. And really, there's several kidney-focused organizations doing exceptional work in that space, and we feel uniquely positioned to address the specific gaps when it comes to health equity and kidney care and where the two overlap. So with that quick introduction, I'd like to say thank you for everyone, and then also extend a heartfelt thank you to Alan Ryan and the team at Ardelyx for their support and partnership in advancing our mission. And we couldn't do this without their sponsorship, and it plays a crucial role in terms of what we do with communities and being able to advocate to improve health outcome for everyone. So I will say this group or alliance is also being chaired by nephrologists, Dr. Maxey and Dr. Gatson, who are speakers here, and everyone that's here is in support and supportive of our alliance. So let me pose my first questions to Dr. Gatson and Dr. Maxey as co-chairs of NEC. How do you all see and envision Nephrologists for Equitable Kidney Care working with other organizations to not only drive policy, but clinical change to make sure optimal kidney care is being extended to marginalized communities? Let me start with you, Dr. Gatson.
Thank you. First, thank you, and good afternoon, or good morning in some places to all. And thank you for giving me the opportunity to be a part of this very challenging seminar. And thank you for all the work that you have done, Mr. Emiru. I think I'm saying that correct.
Yes, you got it.
Well, as one of the co-chairs for NEKC, I see this is really a very important part of clinical practice. I say that because as physicians, we often take care of the patients, but we don't take care of the other issues that might arise. So I see this as a good takeoff block. It is important to have the collaborative input of other organizations. And when I look at those organizations, I'm saying the NMA, AMA, obviously we're under the National Minority Quality Forum, and the nephrology group that has a huge meeting, usually in the fall. There's no name for it, except that it is the Nephrology Week. But in that meeting, though, there is a lot of there's tons of physicians, clinical individuals, research individuals, and also people from across the diaspora other countries, etc. So it's a very international meeting, but it's important because it's a good place to share information and to make issues known that aren't necessarily known. I think what happens with a lot of the things that we do, we kind of hide it under a candle and nobody sees the light. So I think it's important to bring things forward, to people to work collaboratively, to share data, to share information, and to share their thoughts in getting things done.
Thank you so much, Dr. Gatson. And let me turn to you, Dr. Moxie. As a nephrologist and also a past president of NMA, but can you help explain why the American health system is denied this equitable and optimal kidney care to marginalized communities, and why groups like the Nephrologists for Equitable Kidney Care is needed in this space?
Well, I think we need it because I believe the real background of this thing is money or lack thereof. And people don't want to spend money to take care of patients. So what we have to use, Dr. Gatson used a very key word called collaboration. The whole way that the renal system started in 1971-72 was a group of patients on dialysis were empowered to go testify in front of Congress to pass HR 71, HR 72 that financed renal care. And we need to collaborate in forming a patient group, pharmaceutical groups. I agree with Dr. Gatson that we need to also work with the American Society of Nephrology to do this. It's a matter of money and making sure that our patients are worth more than profit. They're worth their lives, and we have to put money to it. And I appreciate what NAQMF and Ardelyx and others are doing to support us to put this back together. I'm very excited about this process.
Thank you, Dr. Maxey. So, and this question go for both of you. Based on your leadership experience at NMA, and you mentioned a moment ago a number of things that need to be done, what actions can be taken to ensure some of these new policies prioritize clinical needs versus other interests, especially when we're thinking about patients who are disproportionately impacted?
I think, first of all, coming up, you have the Black Caucus and the Hispanic Caucus. We should be present there. We should be on the agenda. We should have groups to put together a congressional hearing to do this, and it should include patients, researchers, clinicians as well, and we need a well thought out program to hit these people double barrel. The other thing that's helped other groups in the past, they've had hired lobbyists, and we have to also run people for Congress. I'm glad we have the people from Alabama on. We need people from every state and every territory in the community to back us on this process.
Thank you, Dr. Maxey. Dr. Gatson, will you chime in on this discussion as well in terms of how do we get these policies to prioritize clinical needs, especially when we're thinking about those who are disproportionately impacted?
I think communication is a key, and we don't do enough of that. And this is wonderful. I think the webinars is absolutely excellent. You do this every week, but it's good, and the materials that you're bringing forth. Sometimes people never think about things like this. I mean, who thinks about phosphate binders? If you're not on dialysis, if you don't have kidney failure, if you're not a nephrologist, what do you know about phosphate binders? I mean, it's not something you think about, but it's one of the most important meds that a kidney patient can take. It's probably more important than anything else that they can take. It's that, and I'll explain that a little bit later. But I think communication is one of the keys. I'd like to see all of this, maybe some e-newsletters or whatever, talking about the issues that patients are faced with, that clinicians are faced with, even getting some of the TV stuff. I mean, I just listened, was it yesterday, 2 days ago, about the fact that they're cutting Medicare, cutting Medicaid. That's a patient impact. That would be horrible, just horrible, but that's what they're trying to do. So I think the more we communicate, the better it is. The more we get things out, the better it is. And then have actual steps. No, you don't need to have the phosphate PLTs in a bundle. and the reasons why. So I think it's just important. The communication, I think, is key, and getting the word out of what's going on. Because so many things happen and people aren't aware of it. And all we end up doing at the end is complaining. Okay.
We agree. We don't know what we don't know, unless
Right.
we're personally
Right.
impacted or know someone who does, who is.
But
At some point, we're either all patients or will become one. So navigating a healthcare system and with some of these challenges, I know is overwhelming. So let me bring in the next panelist, as she's used her personal experience and turned it into a powerful advocacy uh, to improve care for others. So Crystal, as a kidney transplant survivor, can you share some of your personal journey and how it shaped your advocacy for improving care for others, especially when it comes to those who are in underserved communities?
Yeah, so I was diagnosed with kidney disease at age 14 after waking up one day, completely swollen and unrecognizable. We went to the Children's Healthcare of Atlanta. It took about a week to come back with a diagnosis of kidney disease. And as I got older and became more in charge of my own health, I found doctors of color who would listen to me, who would answer my questions, who would really help me understand the disease. When I got 36 years old, I got pregnant, married, and we had a baby. And the pregnancy actually sent me into kidney failure. And I went through the process of trying to, advocate for myself, to get on dialysis, get a transplant. I was told that it wasn't time. Back then, the EGFR calculation, which calculates our kidney function, was based on race. And I feel like that had a lot to do with it because this was 2017. And so I suffered, in a lot of pain until 2020 when they said that it was time for me to get the transplant. And so I had a living donor, but the transplant program shut down because of the pandemic. And so I had to start dialysis during the pandemic, one of the scariest things because there's, a mask shortage, there's glove shortage, there's no hand sanitizer, and I'm doing dialysis, at home. Um, and so I was on dialysis, and then I finally got the call that the program had opened back up, and I was able to get a kidney transplant in 2020 as well. And just from sharing my story, my journey, and I mean, I talked about everything on social media daily, and from doing that, I was able to raise a lot of awareness for kidney disease unknowingly. It wasn't my plan. My plan was just to kind of document my life and because I really thought I was going to die. I just wanted proof of my existence. I wanted my son to have memories of us together. And so I kind of became this, I'm like this reluctant kidney influencer. But from doing the work and meeting people in the community and seeing how it affects us at a disproportionate rate, I decided to, take matters into my own hands and kind of start my own nonprofit. So, my experience drives my advocacy today. I'm dedicated to ensuring that every patient, regardless of their background or circumstances, has access to the care that they need through my nonprofit, the Kidney Champion Foundation. We focus on educating historically marginalized communities about kidney disease, and we have three initiatives, which are education, community outreach, and policy. We're all about promoting health equity, whether it's pushing for better access to life-saving therapies or working with patients to ensure that they have the resources that they need to make informed decisions. Our goal is just to make sure that everyone gets the access that they need. Um, and so that's, that kind of that fuels me.
Thank you so much for sharing your personal story and
Mhm.
for turning it around and using it to help others. Let me ask you this as a patient advocate, what are some of the
Mhm.
advocacy strategies your organizations have used or you've used and you find most effective in terms of ensuring not only the healthcare professionals have the tools they need, but patients are aware as we're battling to help improve kidney care?
Yeah, so I would say a big part of it is, finding doctors that you trust, building those networks, those partnerships through organizations, advocacy groups, joining, different support groups for kidney disease, transplant groups, getting involved in policy, as much as you can, and just, continuing to educate yourself about your illness and being aware, of what's going on with you and speaking up, asking questions. If you don't feel comfortable asking questions, or if you feel like the doctors aren't listening to you, bring someone with you. You don't have to go through this alone. Most hospitals, most facilities, have an advocate that can come in and help you advocate if you don't feel comfortable, or like I said, bring a family member or a friend with you to your appointment.
Thank you, Crystal. Let's switch gears a bit and bring in Dr. Blackmore into this conversation. Can you help us break down and explain why this Kidney Patient Act is crucial in terms of ensuring access to these life-saving medications? Also, if you will, mention where the legislation currently stands.
Sure. So the Kidney Patient Act is crucial in preventing the phosphate binding drugs from going into the end renal stage bundle, which the bundle in itself is broken, and we're working to fix it. And so adding anything else into the bundle is definitely going to lower access to services or other products that are also covered within that bundle. So this is a major issue of access, especially in those underserved areas. So, for example, in the Alabama 7 Congressional District, we have a huge rural population who will not be able to travel to a dialysis center without driving over an hour in some cases, and to doing that multiple times a week just to make sure you have access to a drug and make sure you have access to a life-saving service is just something that is not feasible for most of our constituents, or for a lot of our constituents. So that was the main motivation for our office getting involved with the Kidney Patient Act, just making sure those drugs are available to patients who need them the most. The bill, I was really excited, honestly, when the bill came up for Ways and Means Committee markup. It almost passed unanimously. We only had one no vote, which was crucial. It was the first bipartisan bill that the committee passed all Congress. So it was a major victory for both sides of the aisle. And I think that that illustrates that there is support from both Republicans and Dems to make sure that this class of drugs remain out of the bundle. Quickly following the Ways and Means markup, it was marked up on Energy and Commerce as well. And those are the two committees of jurisdiction for healthcare on the House side. So I think the bill is positioned really well to be added into an end of the year vehicle. The bill is scored as budget neutral, so it doesn't cost any money. So honestly, it's an easy win. I think that both sides will want to move on it, and I think that it's no nonsense legislation as far as I'm concerned.
Well, thank you so much, because oftentimes the legislation is can be so complex that people just stay out of it. But in terms of the general public, how can we get the general public to engage in this process and advocate to raise awareness of something like this important legislation?
Yeah, so one of the things that my boss, Congresswoman Terry Sewell, always echoes is that patient voices are so crucial. The patients are the ones that are going to dialysis multiple times a week. They're the ones that have to take these drugs, and I also forgot to mention in my response how important maintaining innovation is within the industry. And so making a move to add these drugs to the bundle would definitely stifle innovation and bring us back to where patients are having to take multiple phosphate binding drugs a day versus one pill that they can take and not have to manage all of the drug management aspect of their conditions. So I think that it's important for patients to reach out to their members of Congress, you know, and have those talks with staffers. You know, it wasn't honestly until Dr. Williams came into my office and educated me on phosphate binders that I was like, wow, we need to do something about this. I have members of my family that have, you know, kidney disease. And so I definitely wouldn't want my loved one to be in a position where they don't have access to this drug. And so to Dr. Gaston points, who thinks about phosphate binders? You know, I think that the patients are well positioned to put that on their member of Congress radar. Like, this is something that we need to move on. And honestly, that's with every like issue in the healthcare space. I think that making sure patients are well knowledgeable about the public policy making process, so that when they're coming in and talk to staffers, they pretty much already understand like what this member can do to move on an issue, and making sure the ask is clear, which for us is making sure this bill makes it into an end of the year vehicle of some sort.
Thank you, Dr. Blackburn, So in terms of, so let me bring in Dr. Fisher. And so the potential implication this will have on patients and the patient experience in terms of having access to these therapeutics. From your clinical experience, and I know you've done some advocacy work as well, how do the kidney care policy changes directly affect patients, especially those from underserved communities who you've worked with, Dr. Fisher?
Hello. Yes, it will definitely influence patients. For patients who are given phosphate lowering therapies. So first off, let's just talk about the minority communities, which we know that we're disproportionately affected when it comes to dialysis. Black people make up only 13.2% of the population in the United States, yet we account for 35% of dialysis patients. And we know that 4 out of 5 patients on dialysis are in need of phosphate lowering therapies. Here's the issue, and this is what I see firsthand as a kidney doctor and as a medical director. It is oftentimes very difficult to find the exact phosphate lowering therapy that will work for a patient. It's not something where you can just grab 1 or 2, put them in a bundle and say, hey, here, one size fits all. It's a very intricate process that requires shared patient and physician decision-making. So if we have policies that limit patients' ability to find that proper phosphate lowering therapy, then we are in a situation where patients, specifically underserved patients, specifically minoritized patients, may have uncontrolled phosphorus, which can lead not only to bone disease and bone fractures, but also to heart disease, to strokes. And so without the proper policies and protections in place, we are dealing with a situation where patients in underserved communities will be disproportionately negatively affected health-wise.
Wow, those are powerful numbers, Dr. Fisher. So again, going back to the point of how do we get the public to learn more about this and the size of the issue, what role do patient education and advocacy play in ensuring that all patients are aware of this policy and changes like the Kidney Patient Act? How can they engage better in the process?
Well, it's like Dr. Gasson said, and like Dr. Blackmore co-signed, who thinks about phosphorus other than me, other than us? No one. And so we just have to keep ringing the alarm. If people don't know that a problem exists, they can't fix it. And quite frankly, what we're here advocating for today is really just common sense. But again, if people aren't aware, they don't know. So what we need to do is really reach out, use all of our influences, be it social media, be it just, social interaction, education, use all of the resources we have to actually present the problem and to present the solution, which at this point is keeping the phosphate lowering therapies out of the bundle. We have to be patient and educate folks. I know that I've done some work like with Dr. Williams, where we've been on Capitol Hill, but of course, very highly educated people who in some cases don't quite understand just how underserved communities are affected. For example, we had someone to very innocently ask the question, well, hey, to lower phosphorus, if you just need to eat healthy foods, then why doesn't everyone just, eat fresh vegetables, like going to Whole Foods and Sprouts, not really understanding that that requires money and not being in a food desert. So sometimes it's as simple as educating people. They're not necessarily full of malice, they just don't know. So we have to ring the alarm, and we have to not sit and assume that everyone is thinking about phosphorus. We have to assume that they're not, and we have to be our patients' advocates by just using our voices.
Absolutely. Thank you, Dr. Fisher. Dr. Williams, let me turn to you on the same topic. How does this CMS decision to add, phosphate lowering therapies to this bundle affect patient outcomes specifically, and what can be done to make sure these life-saving treatments are accessible to patients, especially the underserved patients?
Yeah, no, thanks for having me, and thanks for the question. It's a very good one. I think at the end of the day, I mean, just to step back for a minute, this is a big problem, right? I mean, when you look at chronic kidney disease, it affects 37 million Americans, right? And 800,000 actually end up with kidney failure. And, once the kidneys fail, why are we talking about phosphorus? Why do we think about phosphorus? Well, once the kidneys fail, they can no longer filter out the phosphorus that we take in our diet. And so that is why, as Dr. Gatson said earlier, it is one of the major issues that any patient on dialysis has. And so in terms of, how this issue impacts patients, I think, again, Dr. Fisher alluded to it, managing phosphorus is a very complex issue, and it's a very individualized issue. In other words, all patients don't respond the same way. And innovation is really important in this space. When you think about how do we normally manage serum phosphorus levels or high phosphorus levels, again, diet, but that's not always easy because phosphorus is in everything we eat, in the good food and the bad food. And if I live in a food desert or a food swamp, you can't just tell me to change and modify my diet. Dialysis is the other way that we do it, right? But we are already asking patients to spend 12 hours a week because they do 3 times a week on average, 3.5 hours at a time on dialysis. And so to say we can do more, I think it's a logistical nightmare for the dialysis organizations, and it's a huge burden on patients. So that brings us to medications, right? And for 50 years, we've only had one class of therapy, phosphate binders. And that's fine. But when you look at the data and you look at patients, guess what happens? Nearly 80% of patients, if you look at their phosphorus levels over a 6-month period, they're still not at the target goal. So we need other therapies. And so one of the innovative therapies that just got approved last year is, instead of a phosphate binder, it's a phosphate blocker. And the big issue here is that no one size fits all, right? And we need different medications, different mechanisms of action to tackle any disease. When you think about diabetes, we don't just have metformin. We now have all these other things. We have Ozempic, we have Jardiance, we have all of these other drugs. And putting phosphate lowering therapies into the bundle actually stifles innovation because, if you have a fixed payment system and we're adding new innovative drugs, how does that get paid for? It's not going to be able to, be allocated in that budget in a way that patients have access. And so one of the things that, one of our biggest concerns is that this shared decision-making that happens between the physician and their caregiver goes away because it's now a protocol that is a one-size-fits-all. You get this and only this. That's a problem. The other piece is that access to the more innovative therapies is essentially eliminated when you put these drugs into the bundle system. And so the impact on patients, I think when you think about the fact that 3.5 to 4-fold higher rates in Blacks than non-Blacks, guess who's going to be impacted the most severely? And so it is absolutely critical, I think, to make sure that we fix policies that have the potential, right, to become social determinants of health.
Thank you, Dr. Williams. And from my understanding, as this policy changes loom, it doesn't have any clinical or financial benefit. But as we're thinking about some of these challenges, what do you foresee for patients in terms of having access to these life-saving therapies if the bundling goes into effect? I know you mentioned some of those challenges, but what would patients have to deal with if they now have to think about a new therapy, or how will they navigate that space?
Yeah, and I think that's a very important question. I think in the past, when CMS put these rules together in 2011, I think there were the mindset was and the thinking was, I think, from a very good place. And it started with drugs that were used to treat anemia. But guess what? There was a lot of data that supported those changes. There was data that said if we raise people's, blood count too high, that is problematic. Since 2018, though, all of these drugs that have now been put into the bundle, the more innovative ones have been essentially eliminated in terms of access. Patients, I mean, ask Dr. Fisher, there are drugs that she can't actually get because they're now in the bundle. And so I think what it does is we already talked about the fact that patients aren't currently reaching their target levels. And so when you now you take things from the toolbox instead of adding things to the toolbox, it makes it even more difficult to get patients to where they need to be. And so at the end of the day, it's the patients who suffer. Their phosphorus levels don't get to where they need to be. The additional sort of complications that Dr. Fisher talked about in terms of cardiovascular morbidity, mortality, bone disease, all of those things become even more of an issue. And so this is cost neutral. We're basically saying leave the system as it is. These drugs are currently being paid for in Medicare Part D, and patients have full access to the full realm of all of the phosphate lowering therapies. Why do we want to limit their access? Particularly when there is no financial reason to do it. And more importantly, from an outcome standpoint, from a health standpoint, from a patient standpoint, this is not good for patients. There is no data that says that doing this is a good thing. So unlike data that was there before for other drugs, there is no data that says moving these drugs into the bundle system would benefit patients.
Wow. Well, thank you, Dr. Williams. Let's talk strategies and success in terms of advocacy. Bring in Dr. Hartford. With your experience in expanding dialysis services to underserved regions, what are some of these critical steps that are needed to ensure these kidney care is more equitable, not just in urban underserved areas, but even in rural communities? And how can we better advocate for some of these changes? Dr. Hartford.
Excuse me, I'm sorry. Just hearing what the other panelists have been speaking about is very important thematically to look at its patient collaboration. We need to look at how do we empower the patients. Dr. Gaston has said it, Dr. Blackmore has said it, Dr. Fisher has said it. We need to get the patients to understand more what's going on with policy. They are the end users. Whatever happens with policy, what's going to happen is they're going to be the end result of what happens between their relationship with the dialysis units with their physicians, and how do we work with them to be able to empower them, get them, increase their awareness and knowledge so that they themselves can be able to be that collaborative voice that goes to Congress, goes to the Senate, and actually shares with them what at the most granular level happens to these patients when they do not have access. What's more important for me also is that dialysis units, the multidisciplinary team becomes the second family for these patients. And when you start bringing in policies that don't make any sense, like our patients always say, don't fix what's not broken. Dr. Williams said it very eloquently, is that there is no reason to change and bring in these PLTs into the bundle. What we need to do is to be able to empower these patients to be able to understand more what is going on with health policy, what is going to impact them. We also need to bring in our more representation, bring in the voice to our congressional our representatives, our Senate representatives, and to the Ways and Means Committee. Years ago, I recommended that since 1972, and then we had 2008, when the new regs came in for conditions for the dialysis units. In 2011, we bring in these new regs for the bundled. What has happened since 2011 and now? Has there been any recent congressional hearing or the group, such as a vehicle that we could use, which is the National Minority Quality Forum, that can go and request a meeting with the Secretary of Health, request a Senate hearing so that they can hear from the patients what is really happening in the rural and underserved areas? Because I think sometimes the detail and the translation gets lost when you're making all the decisions at top, but at the bottom right here, you're not seeing what the patient is saying. And many of these patients are tired, they're chronically ill, and they need an advocate for them. They need their caregiver to step in and help. And when you begin to protocolize these processes, you begin to break up that relationship that the patient has with their nephrologist, with their nephrology nurse, their dietitian, their social worker. So you are now breaking something that's not broken. It doesn't need to be fixed. So two things: patient empowerment, and we've got to be able to have more of a voice with Congress and the Senate. And I really advocate we need to have some type of congressional hearing in DC and request a meeting or an event with the Secretary of Health so he can hear what's going on with the dialysis population, because every dialysis population has a unique characteristic profile regionally.
Thank you so much, Dr. Hartford. I like that you've given us some specifics. In terms of some actionable steps, how do we make sure these patients that we're talking about, and how do we connect the dots so that there's a collaboration between the kidney patients and the clinicians who are treating them, and even the policymakers, and so that everyone is in sync and an understanding of what their clinical benefits are, and that's prioritized over everything else?
I think at the most local level, at the state level, and with state representatives where these patients are residing, we need to have more town hall meetings and then raise it up to the next higher level. And that is in Washington, DC at the state. Bring it into the regional offices. What 10, 11 regional offices with HHS? We need to bring it at that level. Bring it to the CMS offices. And through those steps, we bring all the way high up into Washington, DC and the Secretary of Health. But you need the patients, and we need a vehicle. And while you said it very well, Michael, that there's a number of vehicles that have done well, but we need a vehicle such as the National Minority Quality Forum that can definitely represent the group and represent what we stand for in terms of, how dialysis is disproportionately affects the kidney failure, affects these minority populations in underserved areas. And let's not even talk about underserved or rural territories, everybody.
Thank you, Dr. Hartford. Let me remind all of our audience to see if you have any questions or any of the topics that we've addressed. We're going to save the last 10 minutes or so for these questions, so please put them in the Q&A function. I believe we already have a couple of questions in there, and we'll be reading them off. Michael, do we want to get started with some of the questions that came in initially?
Yes. The first question was more of a general topic, but it was focused on talking about policy implications of this decision on pediatric kidney care. That was the topic. So I'll open that up to any of the panelists. Does anyone want to take it?
Dr. Fisher, I don't know if you want to address it, but for dialysis patients of any age that have issues with phosphate control, I would think this would apply, but I'll let you address it.
Yes, absolutely. So I do practice adult nephrology, but prior to completing my fellowship in adult nephrology at Emory, I actually attended Georgetown, where I did a combined internal medicine pediatrics residency and then got board certified in both medicine and pediatrics. So I do have experience in dealing with pediatric patients. And as we know, with phosphorus, it's very important for bone health. And of course, when you're dealing with the pediatric population and bones that are actually growing, it's of the utmost importance that their phosphorus is under control, as well as their calcium balance. So in dealing with these policies, we know that if you don't have control and shared patient doctor decision-making for adults, you're not going to have it for the pediatric patients. And so all populations will be affected by these policies, including our pediatric kidney population.
And I'll also hop into the Kidney Patient Act deals with the Medicare program, but we all know that from just history, what Medicare does, everybody else in the pipeline follows. So Medicaid, private insurance. And so if we can protect the drugs at the Medicare level, we can protect them across all programs, including for pediatrics that are covered through private insurance or CHIPS program or the Medicaid program. So it's important from a point of access that this bill does well in Congress.
Thank you for shedding the light on that, Dr. Williams, Dr. Fisher, and as well, Dr. Blackmore. There is a question in the chat from an audience member that's asking about the bill. I'm sure we mentioned it, but I don't know if we've mentioned, has the bills been officially scored by OMB?
Not by OMB. The bills were scored as having no cost by the Congressional Budget Office. And that's pretty much what CBO pretty much has jurisdiction over, like scoring bills in the in Congress. So it won't have an OMB score, but it does have a CBO score.
And if, just to add to that, the two bills, one from the House, one from the Senate, the one in the House is HR 5074, the one in the Senate is 4510. They're the same bill, Kidney Patient Act, and as Dr. Blackmore just alluded to, they've all gone through the steps that they need to. I think we're at a point now where just making sure that there's a vehicle to attach them so that hopefully they can pass.
Thank you, Dr. Williams. Michael, do you want to go to that second question that was entered initially?
Yes, so this is open to any one of the panelists, but we had a question come in yesterday from an audience member who registered, and the question is, what initiatives are being taken to make sure no patients are left behind due to their location, especially those who live in Puerto Rico, Guam, and other U.S. territories?
I can take that one. We've made some already initial, conducted initial communications to the our local regulatory offices, both with CMS and communicate with HHS with specific territories, the more larger territories. And in that, we're also working with communicating with the renal networks as well to find out if this passes, what is going to be the impact to these patients. So a lot of it is doing the initial communications to increase the awareness with the agencies and also with our medical directors, non-nephrologists, and our patients. We've already begun to educate our patients as well. So there's a lot going on. Again, I call it the most granular level. And this move will move to from bottom all the way up, and then moving up into the Senate and the House, so that we need to get a presence and need to get a voice collaboratively, with the patients and with our nephrology groups and all the stakeholders.
Thank you, Dr. Hartford. I'm just going to continue reading the questions to see how many of them we can answer in the last 10 minutes we got left. I love the audience participation. There's a question in here from an audience member asking about how are these dialysis centers going to support the dispensing of large volume phosphate binders? And will CMS bundle payment be inclusive of the cost of this? And if not, what would a potential out-of-pocket be for patient, since we can assume that dialysis centers would be passing that cost down to the patient? I think we're getting into hypotheticals, but I'm sure we can probably give some sort of an answer on this.
I can answer the first part of it. Not gonna, Maureen, I think what it is I know for every state has different regulations and policies regarding either the administration of drugs or the dispensing of drugs. And this will become a very challenging issue logistically if dialysis units are going to be required to either one, work with another pharmacy outside the facility, to be able to coordinate all the PLT therapy, because imagine a dialysis unit having to require space to keep all the drugs in. If there's going to be greater oversight, greater management, putting a greater burden on the nephrologist and on the patients to try and work with the facilities to be able to better manage and dispense these medications. And it's also important to know that even before you can move in this direction, the local law has to be able to support the federal law in how we're going to be able to operationalize the dispensing of these drugs. So this is going to be very, very difficult. And I have to say that, again, I go back to the most granular level. It's going to be very difficult to work at the facility level, especially those in the rural areas, urban underserved, areas where you have nursing shortages, nephrology, all of these shortages that are coming up. And you've seen a consolidation of the market with these dialysis units. Why? Because a lot of it is there's a shortage of nurses. Now you're trying to add another layer of operational management. You're asking us, dialysis units in general, even to the help of the nephrologists and the patients, how are we going to dispense this? But dialysis units rely on local regulation by the state. So we're going to have to be able to work and hope that the state is going to align their regulations and measures with federal law. So it's going to be a challenge.
Yeah, and if I could add to that, you're absolutely right. I think a logistical nightmare. But I want to just shed some light on the fact that it's totally unnecessary. Because here's the deal, the bundle payment system pays for the dialysis service when that patient sits in the chair. It pays for any medications that need to be given during the dialysis session. It pays for any blood work that needs to be done during that session, and it pays for the dialysis staff that are taking care of that patient. Well, guess what? Phosphate lowering therapies are not given, they have to be given with food, right? And you can't eat during dialysis. So these shouldn't even be in the bundle system because, again, they are not adjacent to a renal dialysis service. These aren't, phosphate binders are taken 3 times a day with meals. So we're basically imposing administration of a medication that is not necessary during a dialysis session. Not only is it not necessary, it is, patients can't eat when they're sitting in a dialysis chair. So it's just not only is it logistically, impractical, it's just not logical.
Thank you, Dr. Williams. This
I
next,
add one other comment to Dr. Williams. I think is really important because since we're talking policy, we're talking regulation. CMS under the Code of Federal Regs does not identify a pharmacist as part of the multidisciplinary team. If we begin to implement this program, the PLTs into the bundle payment, dialysis units are going to require to have some type of pharmaceutical presence, whether it be a pharmacist or access to a pharmacist, which is going to, again, add another layer of operational challenge and also working with the nephrologist and these doctors. So I think we need to go back to how the regs were set up initially and look at how does CMS expect the dialysis units to be able to operationalize the program, especially now we're becoming a dispenser of medications without a pharmacist in the dialysis unit.
Yeah.
Very challenging.
May I just say a few? Oh, all statements have been on point, and Dr. Williams, really nailed it. It is like, why are you fixing something that's not broken? But her point is so valid. I mean, the phosphate lowering therapy it's something, you're exactly correct. Patients take it 3 times a day if they eat. You got to eat and then you take the medications. So with what they want to do, the bundle, it just so totally dissipates that. So that is poor health care. That's going to lead to, you'll never get any phosphorus levels under control. You'll never do it with that, doing it like that. And then you'll lead to other issues, the bone disease, cardiovascular disease, et cetera, et cetera. So in some ways, they want to look at it and say, oh, well, we're lowering the cost. No, you're not really lowering the cost. You're actually increasing costs if you don't do it correctly and people have other issues. And the point that it's not one size fits all. You know, they probably want to use the cheapest one, calcium acetate, which is probably not a good one to use at all anyway. But there are many others that work better, but it depends on the patient and their response. So if you go and say, this is the one you're going to use, then that's poor as well. So I think it's just so important that we continue with this advocacy, continue rolling the can and making the noise down the street in order to get issues heard and also issues dealt with.
Thank you so much, Dr. Gatton. And on that topic, I want to squeeze one more question in. I'm going to address this to you, Dr. Maxey, since you've done this type of work in the cardiovascular space before. So this is a question about many patient groups, and I'm going to use acronym here for the sake of time, like AAKP, AKF, NKF, among many others, and provider groups like ASN, RPA, RHA, NMA, all kidney-related groups, among many others, have all voiced support for this Kidney Patient Act. So someone's asking, what else can be done?
Well, I think it's very important to collaborate with other groups, and if they don't exist, to start a new one. But I think in the coming weeks, we ought to demand a meeting with the Secretary of Health, because obviously they need more education to be trying to stop this type of legislation. We want it to go in our favor. We want to meet with the National Medical Association, the Congressional Black Caucus, and I think we ought to meet with the Secretary of Health as soon as possible and the Congressional Black Caucus with these groups. And I think that offline we ought to collaborate how we can put that together.
Thank you so much, Dr. Maxey. So final thoughts as we wrap up today's webinar. We're coming up close on time. I want to sincerely thank every one of you incredible panelists and speakers. I thought this was a very rich conversation. And thank you for sharing your experience, Crystal, and personal stories that fuel all of us. A big thank you as well to our audience and for your engagement, participation in these questions, and everyone who worked behind the scenes to make this event possible. Our one call to action, again, as you've heard it highlighted multiple times, is to encourage everyone to stay engaged, to get involved, and use the links and resources that we've provided to you all about the Kidney Patient Act, and explore our mission from NEC, that's the Nephrologists for Equitable Kidney Care as well. Visit our website, and let's continue this momentum going and fight for patients. Thank you again for being a part of this important discussion. I look forward to staying connected with you all, and have a wonderful weekend.